to EDGE Journal Watch. I'm Dr. Sharma, cardiac electrophysiologist, and thanks for joining me today. This episode is about going beyond the lesion, because ablation isn't just about what we burn or pulse inside the left atrium. It's about the biology, the substrate, the medications, and the decisions we make after the procedure. Here's the big question for today. If your patient is AF-free after ablation, do they still need anticoagulation? And a second one, maybe even more uncomfortable, does ablation truly work, or are we just seeing placebo with better technology? Today, we'll walk through 4 focused chapters: anticoagulation after ablation, sham-controlled ablation trials, metabolic drugs as rhythm tools, and sex differences in sinus node biology. Chapter 1. Anticoagulation after so-called successful atrial fibrillation ablation. This is where dogma meets data. For years, we've told patients your CHA2DS2-VASc score doesn't change just because you had an ablation. That statement is still guideline consistent, but the evidence underneath it is starting to evolve. Let's start with Ocean. This was a randomized trial comparing rivaroxaban versus aspirin after AF ablation. Importantly, this was not a high-risk population. These were patients with relatively low stroke risk, low documented AF burden post-ablation, and close rhythm follow-up. The primary endpoint was a composite of thromboembolic events and major bleeding. And what stood out was this: absolute stroke rates were extremely low in both arms. Rivaroxaban did not clearly outperform aspirin for ischemic events, but bleeding, particularly clinically relevant non-major bleeding, was higher in the DOAC arm. The key limitation? Aspirin is not considered adequate stroke prevention in AF. So this trial doesn't tell us aspirin is good. It tells us that in a very select, low-risk, closely monitored post-ablation population, the incremental benefit of full-dose anticoagulation may be small. Now contrast that with a lone AF trial. This trial pushed the envelope further. Patients had to be arrhythmia-free for a prolonged period, typically at least 12 months, with structured rhythm monitoring before anticoagulation cessation. The population again skewed toward lower stroke risk, but not zero risk. And the primary outcome was net clinical benefit: ischemic stroke, systemic embolism, major bleeding, and death. What drove the signal was bleeding. Stopping anticoagulation significantly reduced bleeding events while ischemic events remained infrequent. But, and this matters, the trial was underpowered to definitively exclude small differences in stroke risk. So here's the clinical synthesis. These trials do not justify routine anticoagulation cessation. They do justify a de-escalation conversation in carefully selected patients, particularly those with low CHA2DS2-VASc scores, durable rhythm control, and high bleeding risk. Chapter 2. Sham-controlled ablation trials. Sham trials are uncomfortable, but they're the only way to separate true physiologic benefit from expectation and placebo. SHAM-PVI was elegantly designed. Patients with symptomatic paroxysmal AF were randomized to true cryoballoon PVI versus a sham procedure, same cath lab, same sedation, same vascular access, but no pulmonary vein isolation in the control arm. Both groups improved, which reminds us that placebo and regression to the mean are real. But the ablation group showed significantly greater reductions in AF burden and greater improvements in quality of life scores. The limitation? This was a relatively small study, not powered for hard outcomes like stroke or mortality. It was designed to answer one question: does PVI itself provide benefit beyond expectation? Then came PFA-SHAM trial. Same principle, but now using pulsed field ablation. And the separation between groups was even clearer. AF burden, symptom scores, and patient-reported outcomes all favored PFA. Importantly, safety signals remained favorable, reinforcing the non-thermal advantage of pulsed field energy. Taken together, these trials settle a long-standing debate. Ablation benefit is not just psychological, it is mechanistic, reproducible, and now demonstrated across energy sources. Chapter 3, Section A, Metabolic Substrate Therapy After AF Ablation, where the signal actually lives. For an electrophysiology audience, the framing is critical. These agents are not antiarrhythmic drugs. They are substrate modifiers, and when the substrate is metabolic, the signal becomes visible. Let's start with the strongest signal, GLP-1 receptor agonist therapy, particularly semaglutide. The studied populations were not general post-ablation cohorts. These analyses were enriched for patients with obesity, insulin resistance, and type 2 diabetes, the very patients in whom atrial fibrillation is driven by inflammation, epicardial fat, autonomic imbalance, and adverse atrial remodeling. Semaglutide was introduced as part of metabolic therapy, and AF recurrence after ablation was the key outcome. Across datasets, the signal consistently favored lower recurrence rates and more durable rhythm control, particularly in patients who achieved meaningful weight loss. Mechanistically, this makes sense. GLP-1 therapy reduces adiposity, dampens inflammatory signaling, improves glycemic control and blood pressure, and may favorably influence autonomic tone. In other words, you are not treating pulmonary veins, you are treating the atrial environment. The limitations are important. These are not purpose-built randomized AF recurrence trials. Monitoring intensity varies, and confounding is real. Patients on semaglutide often receive better overall cardiometabolic care, so this remains a strong signal, not definitive proof. Now let's talk about the sleeper agent here, metformin. The metformin signal comes from obese cohorts, including patients without overt diabetes. That distinction matters because it isolates insulin resistance and inflammation rather than hyperglycemia alone. Metformin use was associated with lower AF recurrence after ablation. The hypothesized mechanisms include improved insulin sensitivity, reduced systemic inflammation, favorable effects on weight trajectory, and downstream impact on atrial fibrosis pathways. Again, the limitations mirror those of semaglutide, largely observational data, selection bias in prescribing, and variability in rhythm surveillance. But biologically, the signal aligns with what we know about AF substrate. Chapter 3, Section B, DARE-AF, dapagliflozin, and why neutral trials still teach us something. DARE-AF evaluated dapagliflozin, an SGLT2 inhibitor, in patients following AF ablation, and the headline result was neutral, no significant reduction in AF recurrence, but the most important detail is the population. This was not a cohort enriched for advanced metabolic substrate. Many patients were metabolically low risk, and the drug was effectively tested as if it were a rhythm-modifying agent. From a mechanistic standpoint, that sets the trial up for neutrality. Substrate therapy only works when the substrate is present. If inflammation, adiposity, and insulin resistance are not major drivers, there may be little biology for the drug to modify. Additional limitations include recurrence detection strategies, follow-up duration relative to remodeling timelines, and the possibility that benefits on atrial pressure, heart failure physiology, or longer-term structural remodeling were not captured by short-term recurrence endpoints. So here's the EP level synthesis. Semaglutide and metformin show reproducible signals when used in metabolically enriched populations. DARE-AF reminds us that not every metabolic drug should be expected to reduce AF recurrence, especially when tested in the wrong substrate. The broader lesson is this: durable rhythm control after ablation is not just about lesion durability. It's about what systemic disease processes continue to act on the atria after the procedure. If you want fewer recurrences, don't just ask what catheter you used, ask what substrate you treated and what substrate you left behind. Chapter 4, Section A, Genetic and transcriptomic sex differences in the human sinus node and why they matter clinically. I'm going to intentionally go a little off track here because while preparing this episode, I came across a paper that I think is underappreciated but incredibly relevant to everyday electrophysiology practice. This work is based on transcriptomic analysis of human sinoatrial node tissue, not animal models, not inferred physiology, but direct gene expression profiling of the native pacemaker. What the investigators found was a clear sex-specific genetic signature. In women, there was higher expression of genes involved in intrinsic pacemaker function, particularly ion channel and calcium handling pathways that govern spontaneous depolarization. These included enrichment of hyperpolarization-activated cyclic nucleotide-gated channel pathways, inward current regulation, and calcium clock-related signaling, the molecular machinery that drives phase 4 depolarization and sets intrinsic firing rate. In contrast, male sinoatrial node tissue showed greater expression of genes related to extracellular matrix organization, collagen synthesis, fibroblast activation, and pro-inflammatory signaling cascades. In other words, the male sinus node transcriptome skews towards structural remodeling rather than automaticity. This difference becomes more pronounced with aging, providing a biologic explanation for what we see clinically. Women tending to have higher resting sinus rates across adulthood and men demonstrating a higher prevalence of sinus node dysfunction, pauses, and chronotropic incompetence later in life. Importantly, this is not about hormones alone. These are intrinsic gene expression differences within the sinus node itself, suggesting sex-specific programming of the cardiac conduction system. Clinically, this should give us pause. A resting heart rate in the high 80s or 90s in a woman may reflect normal pacemaker biology rather than pathology. And early sinus node disease in men may reflect progressive fibrotic vulnerability, not simply medication effect or deconditioning. This doesn't eliminate the need for thoughtful evaluation, but it should change how reflexively we label sinus tachycardia as inappropriate and how we contextualize rate-related symptoms across sex, age, and underlying biology. Chapter 5, Section B, Pulling the Evidence Together and Translating It into Practice. Let's step back and synthesize what these trials collectively tell us. First, sham-controlled trials have answered a long-standing question. Ablation works. The benefit is not simply expectation or placebo, it is a real reduction in atrial fibrillation burden and improvement in quality of life, demonstrated across both thermal energy and pulsed field ablation. Second, anticoagulation after ablation is no longer a purely binary discussion. Trials such as Ocean and Alone suggest that in carefully selected, closely monitored, lower-risk patients, de-escalation may be reasonable, largely driven by bleeding risk, while recognizing that these studies are not powered to completely eliminate residual stroke risk. Third, metabolic therapy reframes rhythm management. Semaglutide and metformin show signals for reduced recurrence after ablation when metabolic substrate is present, obesity, insulin resistance, or diabetes. The neutral DARE-AF trial reminds us that substrate therapy only works when the substrate actually exists. The unifying theme across all of this is that durable rhythm control is not just procedural, it is biologic. It depends on the atrial environment we leave behind after the catheter comes out. If you'd like more detail, including trial-by-trial summaries, graphics, and full references, all of that is available in my LinkedIn newsletter, EDGE Journal Watch. And if you have any questions, concerns, or want to discuss how this applies to your practice, you can email me directly at epedgecast@gmail.com. Thanks for listening. This is Dr. Sharma. Bye for now.